There we go. So how common is skin cancer? I think everybody who lives in California knows someone or has had skin cancers. So it's by far the most common type of skin cancer, but there's basics to it. Of course, skin cancers are named three different types because the skin has three different layers. The top layer is the epidermis, and the lower level is the dermis, and then there's the subcutis or underneath the dermis. But the different layers in the epidermis have different types. The basal cell, my cursor doesn't work on these. The basal cell is the lowest level. Melanocytes are where melanoma comes from, and then squamous cells are on the top, and that's where the squamous cell comes from. So these are the types. Basal and squamous cell are by far the most common types and very common. And about 8 out of 10 of those are the basal cell type of skin cancer. 2 out of 10 are the squamous cell type of skin cancer. And melanoma is much less common in about 1% of skin cancers, but it is the most deadly. So I don't want to belittle the melanoma, but that's a whole talk in itself. And the basal and squamous cell, I see thousands of them a year. And I wanted to go into more detail about how to treat them because there's so many skin cancer surgeons and there's options outside of surgery. I do surgery as well. There's so many different modalities that are used to treat the basal and squamous cell type of skin cancers. So that's kind of what I wanted to focus on. Basal cell and squamous cell, start in that layer, tend to be very slow growing and rarely spread to the lymph nodes. Although I've seen pretty bad basal cells that do spread, and likewise, I've seen squamous cell carcinomas that don't go to the lymph nodes that are very large as well. And I'm going to show you examples of those. So that's the squamous cell and melanoma. Just usually they're flat, brown or black, but can be pink or tan or white. Oh, I forgot to pull up. I have a picture of one that was all white. But they are also so many more treatment options for melanoma. So it's not like it used to be 10 years ago that basically you had a year to live if you had melanoma, and we only had one treatment, I think. And that's what, all the, not chemotherapy, but immunotherapy and all the targeted therapies for melanoma has really increased survival. Of course, number one cause of skin cancer is sun, UV light, tanning beds, on and on. Fair skin, freckling, light hair, of course, do have higher risk, but that's not the whole picture, because we all know it's like the smoker who never gets lung cancer. We have people who've been out in the sun all their life and never get skin cancer. So there's more to it than that, but we definitely know your risk of getting skin cancer increases with more like long-term sun damage, the sun damage you got when you were 16 through 40 every day living in California. That's more of a risk factor for the non-melanoma skin cancers. For melanoma, it's less clear. That can be a one-time sunburn when you were 12 that can increase your risk. But the non-melanoma skin cancers, 100% linked to sunlight. And here's the same thing, smoking, psoriasis, long-term damage to the skin. Even if you had a burn injury, 50 years later can turn into squamous cell. And of course, being on immunosuppressives, prednisone, long-term, those kind of things can increase your risk. And of course, to catch them early is always the way to go. But some of the squamous cell carcinomas do grow fast, and I'll show you a picture of those too. So it's not necessarily, when you see someone with a large squamous cell or basal cell, it's not necessarily, oh my God, they must have been in denial for 50 years. They can grow within months, kind of thing too. And those are different. And I'm sure you know people who have had those types too. So getting regular skin checks, of course, we recommend that. it is, in my experience, this is doing a self-exam. In my experience, it's usually the patient that finds it before I do, especially melanoma, because, I can check places you can't see, but if you're looking at your skin the whole time, it's 90% of the melanomas are found by the patient in my practice. Skin cancer, signs and symptoms. Basal cell and squamous cell carcinoma would be a brand new bump, grows like a wart, is getting bigger over time, and it can be fairly slowly, but it could be also a sore that doesn't heal. In my men, the basal cell, they'll say, oh, that's just a shaving cut, but it never quite goes away, or it's the same shaving cut over and over again. So that's the other thing we can do now. Good result of COVID is I have my patients take a photo and quickly send it to us on an email. And then we can, know exactly where it was, what that certain spot bled. And when they come to see me, even though it's healed, I know where to look. So I do have patients send, it's not telehealth, but just send photos. So now I'm on to the main part of mine was, what are your options? You have a skin cancer. And I have so many patients who are scared to death to go to the doctor. They, one patient that I'll show you, just deathly afraid of needles. She actually was so afraid of needles, she refused to have it biopsied with lidocaine, and she had the doctor, not me, another dermatologist, do it without lidocaine to get the diagnosis, and it was basal cell. And I'll show you that in a minute. But there's so many other options. One is just freezing. I do that a lot. In ones that I know are superficial, I just freeze skin cancers on the arms, chest, back with liquid nitrogen. But you have to go to someone who knows the depth that they're freezing. If you go to your primary care doctor and they're not used to freezing skin cancers, they can actually make them worse. So only have it done in a board certified dermatologist's office. And then curettage and desiccation is basically scraping and burning. I'll show you an example of that. And the Mohs micrographic surgery and regular surgery, of course, is gold standard on the face and places where you don't want to have a big scar. So you can take the smallest amount around the skin cancer and cut it out, and tissue sparing, I guess. Prescription creams, that's like Aldara or Effudex were the trade names, and Imiquimod and Fluorouracil is the other generic name for them, and they work well. You're supposed to be, put on for 6 weeks, but we can alter it to the patient. 2 weeks on, 2 weeks off. All these kind of things are easily done at home. And then the next one is radiation therapy. Radiation therapy, there's 2 different types, and one is external beam radiation, or when you go for breast cancer, it goes right through the whole body. It's very severe. And the type that we do in my office is superficial radiotherapy. It's very different from what you would get for head and neck cancer or breast cancer. And then surgical excision, of course, that's self-explanatory. And then right on the bottom, I added systemic therapies, which would be targeted chemo and immunotherapy. And Dr. Tom will talk about that in a minute. Okay, so this is my example patient. So she is 92, but very active, very healthy. And her, I think it was her primary care center to an oncologist that wanted to start her on chemotherapy and infusions for these multiple skin cancers. I can't really point with my arrow, but the left cheek one is obvious. That's an example of one that grew very quickly, like over a couple months. The other ones that you can see on her temple, those took years to evolve, but it's not like she neglected herself and was, in denial. These can grow quickly. But she also said, well, I'm not having anything done. I'm ready to go. And this isn't going to kill her. So a different oncologist who works in her office he walked her down the hall and he said, Dr. Allen, can you take care of her? And I did. Like I said, she was very hesitant to come in, so I need to just stop share here. Hold on. I have to go to a different screen. See if I can do it, Shannon. Now I share screen again, but it's going to be this one. And I'll talk about that in a minute. So same patient, she comes in, same day, convince her to have this one treated with simple curettage and desiccation. That was the scraping and burning. So within 10 minutes, she had this growth removed that had been there for months, and it healed like this. She was so happy that she did let me treat the other spots, which she has, if you can see now, can you see my cursor, Shannon?
Yes, I can.
Okay, so she's got multiple ones here. She's got a big one here. She had two on the side of the ear that she was hiding with her hair and were bleeding all over. So I convinced her to use this superficial radiotherapy, which is 2 treatments a week for 30 seconds. She lives right around the corner, drives herself. So within, I think, 4 or 5 treatments, fairly, and this is healing from the C&D site down here. Within 2 or 3 treatments, both of these, or all 3 of these, are shrinking away without any bleeding, ulceration. Well, a little bit, but that's just the scab coming off there and slowly shrinks away. See that one by the earlobes, almost gone. And this is her, I think this was midway through treatment. And this is the other side. So she's very happy, and she still has more we have to work on. But like I said, now I can talk her into using maybe some of these topical treatments and all. So many different ways to skin a cat, I always say, but that's not really a good analogy. Okay, I have to stop share. Go back to the talk. Keynote right here. Yeah, so this is the next case I play on this Mac. This is another one, a woman, this is the one I told you that she was so scared of needles, she would not let the dermatologist that sent her to me do a biopsy with lidocaine. So they just took a little chunk to get the diagnosis of the basal cell carcinoma. But that's what people say, well, which is worse, basal cell or squamous cell? And I've seen really bad basal cells like this one. This one above her eyebrow, she had actually lost the nerve that raises your eyebrow. So she kind of had couldn't raise her eyebrow on that side because of basal cells. So basal cells shouldn't be left forever like this. And obviously this was one that grew over 30 years, not 3 months. This is her mid-treatment with radiation. No bleeding, no scars, no nothing. Well, scars, but that's left from the treatment. And this is her 2 months after 17 treatments. Here it is. Got it. Okay, this is another gentleman. He's an 85-year-old man who obviously is covered in skin cancers. I mean, too many to even start treatment. He did start a topical treatment, or sorry, immunotherapy with Dr. Spling. At the same time, obviously these are bleeding. He has a job. He drives when you buy a new car, he drives them to the place they're supposed to be. And so he was having all this pain, and we treated him with the radiation. This is the device here, a little lead shield, lead gown, eyeglasses, and then this small little part goes over the skin cancer itself. We leave the room for 30 seconds, come back in, he's done. So this is mid-treatment, just kind of drying up, fading away. And he actually only got through about 8 treatments and then was in the hospital for something else, but it went away with 8 treatments rather than 17 treatments. So, and you can see here, he's got so many more that we need to address. And that's where the immunotherapy infusion would come in on him. And that's the machine itself. It's basically X-ray therapies or X-ray beams. This is the hand he would drive with, and he was in so much pain. This is mid-treatment, and this is after, I think, 10 treatments, and this is him after. This is another reason to use superficial radiotherapy is places like on the shin where the skin is so tight, it would never heal. Again, very simple, 30 seconds, twice a week. There's another dermatologist in North County, Dr. Platterotti, who started doing this too. And he does it Monday, Wednesday, Fridays. And I just do Tuesday, Thursdays, but that's just because of our hours. So the lead shield around it. This is that fast growing one. This one grew in about 4 weeks. So very fast growing. It's a keratoacanthoma type of skin cancer, but it's squamous cell carcinoma. And this is after treatment, completely. Actually, that might be mid-treatment. And this is just an example. This is actually basal cell. Can you see my cursor? This little scaly area here. So basal cell can be superficial or it can be a bump. It can look very different. And obviously, he's also a candidate for immunotherapy because has too many to actually cut out every single one. But we work together with the oncologist and we're taking care of him. That's that. Okay, stop share. I think I'm done with my case presentations. I'm going to go back once more to the talk. See if there's anything else here. Play on this Mac. Quickly on melanoma, the ABCDEs, asymmetrical, the border's irregular, the color is different colors. So it can be pink, it can be red, white, blue, different colors within one mole. And the diameter is usually bigger than a pencil eraser. So there's an example of perfectly round, normal shape, and different examples of melanoma. And this is American Cancer Society. Their slides, their info for skin cancer patients is really good. And the other one is the AAD.org. And that's where you should find your dermatologist, is a board certified dermatologist. There's a lot of people who say I specialize in dermatology, but they're not board certified. Mm-hmm. And Tom, you want to come and give your little talk on immunotherapy? Did you? Yeah, I traded. You like how I passed the buck there?
Hi, guys. I'm Karen's husband. That's how come we are living together. So it's not weird. My name is Dr. Spillane. I'm a medical oncologist. And yeah, I'm proud to say I think we do a great job with treating cancer patients here in San Luis Obispo, and especially because of Shannon and Julie's help in keeping our Hearst Cancer Research Center, all the support stuff together so that we can do educational stuff like this. So the office where Dr. Allen and I work, we're pretty much the only office that I know of anywhere in the Central Coast that does a combination of things for skin cancers, which would include Mohs surgery, which Karen is specialized in, which is, she didn't really talk too much about that, but that's something she's also very good at, as well as doing superficial radiation therapy, and also having in our same clinic the ability to infuse patients with systemic therapy. And systemic therapy basically means something that's going to go throughout the body through the bloodstream so that it attacks cancer cells kind of from the inside out, and pretty much can attack cancer anywhere in the body. The treatments that we use are not chemotherapy. We really don't use chemotherapy for skin cancer. But we use a couple different things. One is called immunotherapy. And I think you've probably all heard that we all have cancer cells circulating around our body all the time. However, our immune systems, if they're healthy, they recognize cancer cells as being foreign and something that needs to be removed. And so our immune systems go in and get rid of cancer cells all the time. So when a cancer starts growing, that means that it has escaped the surveillance of the immune system, and somehow it has found a way to evade the immune system, almost like having a cloaking device. So it sits there invisible to the immune system. So there's a class of drugs that are called checkpoint inhibitors, and they remove this cloaking device so that now the immune system can recognize cancer cells and go in and gobble them up. And so, generally it's pretty well tolerated. And so that's a great way of getting rid of cancers, especially skin cancers that are too big to be removed surgically, or are in a difficult location where they can't do surgery, or sometimes they're too big for the superficial radiation therapy that Karen does. And sometimes squamous cell cancer of the skin and basal cell cancer of the skin can spread. And so it can spread, for example, into the lungs. And that's when we would use these drugs that we call checkpoint inhibitors that are given intravenously. Often they're given every 2 weeks or every 3 weeks. And it takes often sometimes 6 months to see the cancers melting away. And a lot of patients like the one she showed earlier, after about a year or so, he's doing great. So we stopped and followed him for a year or so. And then he may need to go back on it because some cancers are popping up. But generally pretty well tolerated. Immunotherapy is a really game changer in the cancer world that has come about in the last couple of years. Other things we use are targeted therapies. So there's a class of drugs that we call hedgehog inhibitors. And those are, there's 2 different companies that have developed these pills that you would take. And it works really well for basal cell carcinoma. And so in basal cell carcinomas that can't be treated with surgery or radiation therapy, then we'll use targeted therapy. And so we, in our office, we have 4 oncologists that are working there and 2 mid-level practitioners. And kind of having a dermatologist on site makes our lives a lot easier because we have a lot of patients with skin cancers, and we have a lot of patients that develop rashes from their treatments and from their chemotherapy.